Today, December the 11th, 1985, I have the pleasure of being in the home of Dr. J. Lawrence Poole in West Cornwall, Connecticut. Dr. Poole, as many of you know, is the Professor Emeritus and long-term Director of the Neurological Surgical Service at Columbia Presbyterian and the Neurological Institute of New York. I'm particularly privileged to interview Dr. Poole today for the archives of the AANS, as he was my chief when I was in training at the Neurological Institute. Dr. Poole is one of those rare individuals. Not only is he multi-talented, but he's also a native New Yorker. He was educated at St. Paul's School, Harvard College, and Columbia Presbyterian, and the College of Physicians and Surgeons, Columbia University. Dr. Poole, what was it like to practice neurosurgery in New York in the late 1930s?
Well, it was a combination of a lot of hard work and good fun. A lot of hard work because there were only 5 neurosurgeons of my age in New York City then. We had to cover the excuse me, the metropolitan district area and suburban districts as well, because there were no I think there was only 1 neurosurgeon outside of New York in the immediate vicinity. So we'd have many night calls for head injuries, occasional tumors too, at private hospitals and county hospitals, and then most of our work was at city hospitals, mine being at Bellevue Hospital, under the under Dr. Joseph King, who was the chief of neurosurgery there. And Dr. King was one of the old-time was a neurosurgeon who had no formal training, but was a general surgeon, trained himself in neurosurgery, as did Cushing, for that matter.
Well, I remember Dr. King would continue to do general surgery throughout his long career, didn't he?
He did. He'd do a gastrectomy and a thyroidectomy in the morning, come down, do a brain tumor in the afternoon at Bellevue.
Nice times. Tell me about when you came back from World War II, you entered into the long association with the Neurological Institute there. I'd like to talk with you a little bit about some of the people that were there at that time, like Ted Scarf and Dr. Stuckey and Juan Taveras, and that stellar group of people who were around the Institute in those years.
Well, we had a great group, as you indicate. Dr. Charles Ellsberg was the chief of neurosurgery when I was an intern there, and he was one of the first professors of neurosurgery in the country, Dr. Ernie Sachs being the other. Dr. Ellsberg retired, Dr. Stuckey took the chair and was my chief. Scarf was his right-hand man, a dear friend of mine, very able surgeon, interested in the surgery of epilepsy and pediatric surgery. There was another man we seldom hear of who died prematurely, Dr. Clement Masson. He was the fastest surgeon of them all, in my opinion, and I dearly loved to work with him because he wasted no time at all. Some surgeons, as you may recall, were what I call towel surgeons. They spent hours adjusting the drapes and towels, getting them just right.
By that time,
Masson put them on and went to work and operated.
Yes, there were a few. By the time you got the towels on, the disease process had probably cured itself by then. Speaking of the surgeons there, you certainly contributed richly to the neurosurgical armamentarium. For those of you who have come into neurosurgery after the great computer revolution may not realize that Dr. Poole was one of the first neurosurgeons to successfully totally excise 8th nerve tumors, sparing the 7th nerve. He was the first to use temporary occluding clips for aneurysms. In my time at the Institute, it was marvelous to see what you could do with a pair of good hands and good eyes and very little light. Where did you get the idea about the acoustic tumors? That was what you were doing mostly when I was there.
I'll tell you exactly how since this is an informal talk, I'll tell you exactly. We had a joint meeting with the neurologists, neurosurgeons, one afternoon on the subject of acoustic tumors. And one neurologist, who was a very outspoken one, I don't think anyone you know, as a matter of fact, he said, "Poole, what do you know about acoustic tumors?" And that made me so mad that I went into specialized in it and wrote a book on the subject, which came out in the second edition by C.C. Thomas. And I certainly wasn't the first to do a total extirpation, sparing the seventh. Mackenzie certainly was an ace at that in Toronto, who
Yes.
trained Eben Alexander.
And Charlie Drake.
And Charlie Drake.
How big was your series of acoustics when you retired?
I can't remember offhand. I don't think it was a huge series. I suppose close to 100, but I'm not sure. It's all in the book.
Tell me, when did you become interested in aneurysm surgery? And before we get into that too deeply, I'd like to say that there was a great controversy about the treatment of subarachnoid hemorrhage, and it certainly was not considered as an operative condition for many, many years, and Dr. Poole was one of the pioneers in developing that aspect of our specialty.
Well, to backtrack a little bit, Kemp, when I was an intern in neurosurgery from 1937 to 39, at the Neurological Institute, we only saw 4 aneurysms a year, and they were diagnosed on the basis of X-ray findings, erosion of the cella turcica on that side, just plain X-ray findings, or a rim of calcification in the wall of the aneurysm. That's the only clue. There was no arteriography in those days. And occasionally one would be found at operation, a giant aneurysm, and to be sure it wasn't a tumor, the surgeon would stick a needle into it. And if blood came out, he suspected it was an aneurysm. That's literally true.
If he was unlucky, he couldn't get the hole closed.
Yeah, and then the only thing to do, the only thing then that I saw done at least, was to stuff the aneurysm with muscle, and that wasn't a highly successful procedure, as you can imagine. Then arteriography came along after Monet's reported that in 1927 or thereabouts. But that didn't hit this country for 3 or 4 years later. There was quite a lag, and when it did, we used diadrast, which is radioactive, caused liver malignancy.
That's right, thoratrast.
So at Bellevue, a young internist, Stuart Alexander, and I thought we'd try diadrast. It had been used elsewhere at a concentration of 70%, and 70% led to carotid thrombosis and terrible disasters. So we thought we'd use a 35% solution and had great success with that, and that became standard for quite a while. We were the first to report on 35% diadrast.
And it's interesting that now in neurosurgery we think of aneurysms as being sort of the sine qua non, and yet even as when I was a resident at the Institute, you were doing most of the aneurysms at that time. But as I recall, there wasn't one a day or anything like that.
Oh, no. Occasionally I did 2 a day, 2 anterior communicating a day, occasionally because the schedule demanded that. But I did do most of them because I liked it. It was a challenge, and still is. A greater challenge then because the great bugbear was they were so apt to burst as you approached them during the dissection. And for that reason, I thought, why not try temporarily occluding the feeding vessels with temporary clips, removable clips, using hypothermia to do so. Harry Bottrell, as you know, was a pioneer in hypothermia, and Wally Hamby was a pioneer in using a temporary thread around the feeding vessels, a snare device to shut them off if need be.
It's something which nowadays the vascular surgeons call a Ramel clamp, which is too bad because Ramel, I don't think he'd ever heard of it before Hamby used it, which he put around the common carotid in the neck, as I recall.
Yes, but he also used ligatures passed temporarily around the feeding vessels.
Intracranially.
Intracranially. And the 2 ends were slipped through a tube and then pulled up tight if the occasion demanded.
That's right. Of course, one of the problems that I recall in those days as well was the fact that we had no self-closing clips. You had to close a conventional Cushing or silver clip, and that produced a lot of ripping of the aneurysm wall and having them pull off because you'd wiggle your hand as you tighten the clip down.
Yes, that could lead to trouble, as you say. There's an interesting sidelight on the use of hypothermia. When we first started using it, the cooling led to really drastic cardiac irregularities. Sometimes it's the ventricular fibrillation and cardiac arrest. And I thought some of my observations indicated that when you tickle the carotid artery or even the anterior cerebral artery in these humans whose cardiac status was under a very sensitive state, the stimulation of the vessels itself would cause cardiac irregularities, mild ones, but definite ones. And I thought the patient should be more highly sedated to block those impulses, central impulses going to the heart and causing cardiac irregularities. The anesthetists, as they were then called, refused to give any more sedation, such as pentothal, because they thought that would increase the risk of cardiac trouble. So I got Dom Purpura, who was running our laboratory with Ed Harsepian, to do some rapid and very clever experiments on cats who were cooled. The greater they were cooled, the more the cardiac irregularities on central stimulation, which is done by midbrain stereotaxic means. And they demonstrated very clearly and very quickly that if you sedated the cats with pentothal or other blocking agents, they did not develop the cardiac irregularities. This convinced the anesthetist to give more sedation, and then we had no further trouble with the cardiac irregularities under hypothermia.
I remember another contribution that you made, speaking of cardiac arrhythmias. I believe you were the first to point out that subarachnoid hemorrhage many times produces changes in the electrocardiogram that can mimic a heart attack.
No, I didn't count. No, it's somebody else.
Somebody else? Sorry.
I recall that.
Sorry about that.
But,
But the reason I mention it is that seeing as many subarachnoid hemorrhages as we do, it is impressive how many times you do find cardiac arrhythmias along with in the acute phase, which may be simply irritation of the vessels around the base of the brain.
Getting back to the temporary clips, use of that, I decided to make a routine use of that procedure for 5 years, approximately so, and did so with all types of aneurysms, whether they were anterior communicating, middle cerebral, carotid, PC, or even a couple of vertebrals that I had. And it turned out well. The trouble is, if the clips were on too long, then that led to disaster, obviously. I understand now from a symposium on aneurysms that Ben Stein conducted that some people are now going back to the use of temporary clips.
Very much so. In fact, I would say that in our shop, it's rare that we do an aneurysm that we don't at some point in time use a temporary clip. Again, trying to stay within the limits of safety of cerebral ischemia. But it's also interesting that the more distal you get, the further you get away from the major entry vessels, the longer you can leave the clip on without getting into infarction. Tell me a little bit about what you think what now in surgery represents a challenge comparable to that of aneurysms. Would you say arteriovenous malformations?
I would think so, certainly. That's certainly one of them. Yes, and of course deep-seated tumors. Of course, tumors in the brainstem. Although even then we managed to scoop out some astrocytic lesions of the brainstem, especially the cystic variety. Yes, I'd say definitely. And I'd say also the use of stereotaxic means of approaching deep-seated tumors, not only for biopsy, which is done, but even laser and other means of destroying the tumors.
Like Pat Kelly is doing at the Mayo Clinic.
Yes.
And that sort of thing. When did you start using the operating microscope?
That was in 1961, the first time I used it. It was a simple one-man affair, binocular, but one man, no other instrument for the assistant to use. And that was so gratifying to see a little tiny anterior communicating artery look as big as a lead pencil that it was a breeze to continue it from then on. And I was the first to report it. As far as I know, it wasn't reported until 1966, so I had enough cases to make the report worthwhile. It wasn't published until 1966.
No, I know that it certainly opened up a whole world to me. The first time I ever looked through an operating microscope at something. And
it reminded me of scuba diving. You could swim on the surface and not see much, but you go down into there and you see everything large as life and the colors as vivid as life.
That's right. That's right.
Incidentally, Kemp, there's another thing concerning aneurysms that I talked to Bill about on the tape interview a couple of months ago, and that was the fact that I was the first to perform an extracranial intracranial shunt.
Really?
Yes, really, that's right. Yasagil acknowledged this at the very kindly at the aneurysm meeting that Ben Stein and Bob Holtzman put on at the Winston Symposium in Scarsdale 2 years ago. And Yassi said that inspired him to do the shunt, extracranial, intracranial shunts under the microscope, which is direct anastomosis of arteries.
Yes.
Now mine was not that, but it did give him that idea, as he said publicly at that meeting, and that led to the bypass procedures, which in some cases are still necessary, I think. Anyway, this was done with a plastic tube. It was an aneurysm just above the mid-portion of the corpus callosum, and I thought that it might be difficult to get at and clip off, which it was, so I was prepared ahead of time to do this. I put a plastic tube in the temporal artery and loaded it with heparin, and kept it shut off till ready, and then put the distal end, like a first-year medical student's experiment in the lab, put it in the distal end of the anterior cerebral artery. And the red blood from the temporal artery flowed through as pretty as you please, and everything looked great, the tube coursing over the convexity of the cortex. And I thought Bob Merrick from where, Minneapolis? Somewhere
I think
out
that's
there,
where he is, yes.
was my first assistant. And we thought this was just great. Until all of a sudden we were ready to close when the blood in the plastic tubing turned Cambridge blue. And I said, "What's going on?" And the anesthetist woke up at that point and said the tracheal tube is kinked. He unkinked it, and the blood became red again. And I think that's the only good it did, frankly. It saved the patient's life.
That was something good. That was certainly true. Dr. Poole has always been an innovator.
That was in 1951, by the way.
Gee,
reported in my book on aneurysms that I wrote with Gordon Potts, who did the X-ray portion of the book.
Right. Dr. Poole's always been an innovator. Before we had really good myelography, he developed a myeloscope to put in the cauda equina and look around and see what was happening down there. How long ago was that?
That was in 1937, when I was an intern in neurology at the Neurological Institute, and the only myelograms done in those days were done with a substance called lepiodol, sort of an oily substance that caused severe arachnoid adhesions in some patients that led to pain in both legs instead of just one if they had a disc. And I thought, why not look in there if you can, devise this myeloscope like a mini cystoscope, put out by the the American Cystoscope company helped me design. I designed it, they helped build it. And you could see around, but not far enough to really make it worthwhile. But just this week, Kemp, one of the medical officers at the 9th Vac Hospital that was with me in overseas in North Africa and so on, Captain George Parks, Duke Parks, he came up for lunch here just this week. I hadn't seen him for years. And he said, I remember at Bellevue, you did a myeloscopy on one of my patients. Nobody could figure out what was wrong, and found a neurofibroma and operated on it the next day and took it out.
Oh.
And I remember that is so. I did pick up a few tumors, a few discs, and varicosities, which are really arteriovenous malformations. But then good myelography came along and the thing became obsolete.
Dr. Poole had a very interesting background in coming into neurological surgery. I'm sure that he was guided in at least some part by his father, who was a distinguished general surgeon in New York. Not only was he trained in neurology for a year, but he also spent some time in various laboratories prior to taking your neurosurgery training. Isn't that correct?
Yes, Kemp. The old man laid out the old man being Dr. Eugene Poole, was president of the College of Surgeons in his day, and so forth. He laid out a 7-year program for me that I followed scrupulously. First, a year of general medicine, which I took at the New York Hospital when it first moved uptown to East 68th Street. Had a very good year there in general medicine. Then a year in the Harvard's Boston City laboratories on studying the circulation of the brain, which led me to get interested in vasospasm, putting a little window that you could observe the cortical vessels under the microscope with sympathetic nerve stimulation and drug effects on it. And that was a very interesting year there. And then the 2 years following, I had general surgery training at the Presbyterian Hospital, routine gallbladder, appendix, and thyroidectomies. Then a year in neurology, and then 2 years in neurosurgery to wind up, making 7 years.
Wow. Nowadays, the federal government wouldn't fund you for that much time.
My old man funded me. That's what happened. We weren't paid anything.
That's right.
The first time I was paid anything in that 7 years was when I was senior resident in neurosurgery, neuro, and received $125 a month, which I thought was great.
You thought you were rich. Yes. That wasn't R.C.L. Robertson.
R.C.L. Robertson was chief intern or chief resident ahead of me, and I was devoted to him. He was
a wonderful man.
He was a stern taskmaster, but by guys, I never saw him wrong.
Mm. Well, now that you've got all this done in your life, what sort of advice would you give someone who, say, had just finished his senior year in medical school and said, I want to be a neurological surgeon?
Well, I think you ought to pick the best possible training course, which means a training course that includes training in neurology and training in the laboratory. It's essential to have laboratory training so that you can devise your own experimental approaches, but even if you're not going to do that, understand the work of others so that you can tell what's right and what's wrong as to results reported in the literature. So I think neurology, neurosurgery, and general surgery, obviously. I think general surgery to inculcate the basic principles of surgery is essential too.
I wonder why you didn't go into general surgery.
2 reasons. One was I didn't want to ride in the old man's coattails. He was a prominent general surgeon, and I didn't want to, frankly, it must have helped some, but just the same, that would have been too much for my money, so I wanted to do something different. I decided that at the beginning. A. B, because I was fascinated by neurology the first year I took it at medical school. The neat little diagrams, I didn't see how anybody could possibly go wrong and how anybody could fail to make a diagnosis with these Tilney and Riley diagrams of the spinal cord and the pathways in the through the basal ganglia, etc. So that fascinated me. And also it was a new field, a relatively new field. It was wide open for research and investigation.
I guess that's true. See, Dr. Cushing had what? He retired about when, 37 or 38?
Just about then. I went to his 70th birthday party at New Haven, and Dr. Cornelius Dyke, who was our prime X-ray man, one of only 2 or 3 in the country at those days, neuroradiologists. There was Sussman in Boston and Pancoast in Philadelphia, and Corny Dyke. They were the 3 top dogs in neuroradiology. And I was very fond of him, and he took me to the Cushing celebration of the Cushing 70th birthday party as guest, which was very embarrassing, I may say. We took the train to New Haven. The train was late, and we walked into the meeting hall, which was a large classroom, late. Everybody in the Cushing Society, which it was,
yes,
was sitting in the very back rows. They were jam-packed. There was a long hiatus, nobody in the middle seats, except Cushing down front. And we tiptoed in, but he caught us, and Dyke skedaddled up to the back row to join the other members of the Cushing meeting, and Cushing beckoned to me. Come over and sit by me. Nobody dared sit next to him unless they'd be accused of looking too eager, so to speak. You know what I mean?
Yes, exactly.
So I went there as a young squirt and sat next to him, fear and trembling, and he was most kindly pointed out the features of the pituitary experiments that were done on collies and other dogs that were shown. So that was a memorable occasion.
I'm sure it was. All the time that you were at the Institute, you saw a lot of people come and go, I know. What did you enjoy the most about the time that you were there? I might just interject here that I think that you were the chairman there for what,
23 years.
23 years.
Yes, 1949 to 1972. Excuse me. What did I enjoy most?
Yes.
Well, I enjoyed surgery most of all. A and B, the teaching, the contacts with the residents and medical students. And we had medical students out to the house in Alpine across the George Washington Bridge once a month, and the nurses, OR nurses, another weekend once a month, and medical students another. So we kept in touch, thanks to my dear wife, who worked hard to make things hospitable, and I enjoyed those contacts very much indeed.
It's interesting that you mentioned your experimental days in the laboratory working with the vessels and the nerves to the cerebral vessels. Is this what ignited your interest in vasospasm?
Oh, definitely, Kemp. I became interested, and then of course, when we ran into severe vasospasm after subarachnoid hemorrhage from a ruptured aneurysm, it became a problem, and still is. It needed study. And neurologists just didn't believe there was such a thing for quite a while.
Some of them still don't.
I can't believe anybody doesn't believe it now, but I know Kinnear Wilson, in his 2-volume book on neurology, stated in words practically to that effect that there's no such thing as cerebral vasospasm. But I thought if the other vessels, arteries of the body can spaz, so to speak, go into spasm, why not the cerebral vessels? And then I was stimulated to write an article on this subject, prompted by an article in the Archives of Neurology and Psychiatry by a young neurologist whose name I don't recall, but he said, and there are some who still wave the red flag of vasospasm. Well, I didn't know what it meant, but it got my red flag waving. And so I wrote the article on my work and the work of others and my staff on vasospasm, which we were doing at Neuro. An article which was published in the New England Journal of Medicine in 1958 called Cerebral Vasospasm, Experimental, X-ray, and Clinical Evidence. And that stopped the tirade from doubters.
I'd like to thank you, Dr. Poole, for this interview. I'm sure that the people in the future will look forward to seeing it many times. Thank you for having me up here.
Well, thank you for coming. This has been a great honor.